As you can see, it is a beautiful day here at ACC 15 in San Diego. You know, there are some real dilemmas associated with blood transfusions, and we're here to talk about a paper in the March 2015 issue of JACC Interventions. The title is Blood Transfusion After PCI and Risk of Subsequent Adverse Outcomes, a Systematic Review and Meta-Analysis. And I am here with Dr. Sunil V, who is an MD and Associate Professor of Medicine at Duke. Let's start with the optimal use of blood products in patients undergoing PCI. This whole thing remains controversial, doesn't it?
It sure does, and I like the way you phrase it. It really is a dilemma, because remember, a dilemma is trying to choose between two things of equal value. And what we're struggling with blood transfusion is that we know anemia is associated with an increased risk for ischemia, heart failure, recurrent myocardial infarction. Blood transfusion is the easiest way to correct anemia. The problem that we've dealt with is that there is something called the storage lesion. That is, stored blood is probably not like the blood that's coursing through our veins right now. And a lot of observational studies have shown that there is an association between transfusion and those same risks of recurrent myocardial infarction. So it really is a dilemma. Should we use blood transfusion to correct anemia, or are we potentially making the situation worse in those patients? So you're right, it's a very controversial area. We have good data in other areas, so critically ill patients, patients who have an acute GI bleed, where there are randomized studies suggesting that a lower threshold for transfusion is probably okay compared with a higher transfusion. Very recent randomized trial published in patients undergoing cardiac surgery in the New England Journal, again, showing no harm, but not necessarily a benefit. There was a mortality benefit that was seen in the more liberal transfusion arm. It wasn't powered for mortality, so it could be a spurious finding. So this is an open question still, I think.
So what did you do to try and answer some questions?
So we've done a couple of observational studies, and we with a group in the United Kingdom, did a pooled analysis of all of the data that have been published to date. And the data seem fairly consistent. Again, most of it is observational, so we have to be a little bit careful. So we can't use causality language, but it does seem to show that in patients undergoing PCI, that there is an association between the liberal use of transfusion, if you will, and an increased risk for adverse events, with the caveat that there really are observational studies and there's potential for unmeasured confounding. When we have results like that, what we really need is a randomized trial. And those, as you know, are very difficult to do.
So what do we still need to know now that we know a few more things?
So I think what we really need to know is what is the optimal threshold at which we should be transfusing patients who have ischemic heart disease. Does it need to be higher than a patient who doesn't have ischemic heart disease because of the presence of coronary stenosis? So that's one thing we don't know. The other thing we don't know is there an effect of the age of blood? In this recent randomized trial, it didn't seem to be an effective age of blood, but we know that the longer blood is stored on the shelf, potentially the less the oxygen delivering capacity. And then I think probably the most important thing is, can we implement strategies routinely that will ultimately reduce the risk for a patient even needing a transfusion? So how can we minimize those bleeding risks in these patients undergoing PCI? We have very good data on radial access, for example, dosing the anticoagulants appropriately. A little bit of controversy over antithrombin agents that we'll know a little bit more at this meeting at the ACC. But we have some strategies available to us, and we really need to implement those a little bit more widely, I think.
So what's your take home from this?
I think the take-home, I would say the most obvious take-home is that bleeding and transfusion are iatrogenic issues, and that there are strategies available to reduce those risks. Until we have randomized data, we probably should be avoiding routine transfusion and using these bleeding avoidance strategies in our patients.
So this is the JACC Interventions for March 2015. Please see the paper there. For CardioSource World News, I'm Executive Editor Rick McGuire.